about it is that when public health is a success, you don't know that it happened. And the idea there is that we never get to the point where people are sick. No public health official is ever expecting a pat in the back. Because at the end of the day, if they succeeded, they're going to be forgotten. No doctor gets a pat in the back for polio not being an issue in California. We just don't talk about it. Because the interventions, the vaccinations, the programs that are in place are successful. And again, we see that with both the vaccinations as well as other kind of interventions in terms of buckling up and other safety interventions. And again, what it comes down to is context. Public health is about so much more than simply a one-two interaction, a doctor and a patient. It's about socioeconomic status, it's about cultural status, it's about stressors, which is what we're going to focus on in this talk. But it's really important to realize that public health, I'm going to skip over that, public health and medicine are sort of slightly different. Public health takes a much more broad-ranged approach, it takes more of a population-based approach. And I think looking at Islamophobia from that lens introduces us to a new way of approaching this really important issue. So to begin with, I think most of us are familiar with this. It's kind of a normal standardized curve, what a population usually looks like. Now in medicine, we try to kind of develop a threshold. If we're looking at blood pressure, we might say, hey, if your systolics are over 140, we might start talking about medications. We can put you on this, and that. Or we can try getting you below that number, we can approach it in a different way. So basically, we've got a threshold, and we're talking about which side of it are you sitting at. So if you're on the wrong side of it, so you're not, say you're about 150, we're going to talk about treatment. Our goal is to get you over to the other side of that threshold, get you back to a point where you're not as sick, where your numbers aren't as concerning, where you're not at a high of a risk for whatever condition that we're worried about. Now in public health, what we do is we try to move the curve. So I want you to take that, look at that again. It's very subtle. Instead of moving the patient from side to side, we want to talk about moving an entire population. So if we vaccinate for something, our entire population has a certain effect of not being as likely to get whatever condition we're using our intervention to target. So again, if we go back to our definition, we're talking about societies, we're talking about conditions, and we're talking about our preventative care. We're trying to stop things from happening. We're trying to really lower the risk factors for whatever it is that we're talking about. So that's our ideal. What's our reality? So we've been talking about this, I think, all weekend. Islamophobia, in a lot of different ways, is a big issue in our lives, coming at us from many different directions. There's a recent survey that went out, and they were talking about, in America, what group do we think is the most discriminated against? And it was interesting to see above 70% of Americans actually identified American Muslims as the most discriminated against group. That number was above the level they identified for African Americans or Latino Americans. So not only is this issue that we talk about internally, even outside of our immediate community, at a kind of a population level here in the United States, this is something that's being recognized because it's so striking. So this has been happening for a while. We've seen rapid socio-political changes over the last 15 years now. It's affected us in a variety of different ways. But in addition to that, we've also had our internal struggles. It's been looked at in multiple fields of literature, both psychology, mental health in terms of psychiatry, as well as public health, that within many minority communities, amongst those often being the South Asian communities as well as the Arab communities, we struggle with some of these issues. We don't like talking about issues of mental health. We don't like talking about things like depression and suicide. These are taboo topics both culturally and now also with a generational gap that begins to develop, which also complicates the conversation, and that's a whole different talk waiting to happen. In addition to that, we also have issues of isolation, assimilations, things that we begin to really look at from an anthropological standpoint. There's a lot of work and a lot of talk to be done there. And we also have a certain degree of rejection. These things don't happen to us. We don't get PTSD. We don't get depression. We're kind of above this, that we're Muslim, that we will focus in on our faith, regardless of whether or not there's an underlying mental health issue that we need to be talking about. So I think it's multifaceted in that sense. So looking at it again at that curve we talked about, what happens here is that our curve, instead of moving away from the threshold, we move towards it. Because of these stressors that we have in our lives, prescribed discrimination being one that we're talking about today, we begin to put ourselves at a higher likelihood of being sick, of having whatever condition we're talking about. We're moving in the wrong direction. So the way that we talk about this from a psychology background is that we talk about it as stress. So the American Psychological Association talks about stress in 3 ways. It kind of breaks it down into something really simple. First being acute stress. Now this is kind of your normal fight or flight response. Something happens, you get worked up, and you take care of it. It might be an emotional thing, it might be a skeletal thing. You've got a pain somewhere and your body's responding in a certain way. But more importantly, it's more of just a single and acute event. Then you've got episodic stress. Now, episodic stress is somebody where these type of acute events happen to a lot. I think we've all got some of these people in our lives that tend to get stressed out a little faster, a little bit more often. You can call them type A personalities. And in addition to that, there's some research talking about how cardiovascular risk factors are often affected by people who are a little bit more high-strung in that sense. But in particular, what I want to focus in on is chronic stress. Now, chronic stress is the one that's really worrisome, because it's the kind of stress that really kind of breaks you down physically, emotionally, psychologically. It's the kind of stress that you experience when you're living in a war zone. It's the kind of stress that you experience when you're growing up in a dysfunctional family. And it's also the kind of stress that minorities often experience when they're put through levels of discrimination or oppression, whether that's a religious minority, a racial minority, a cultural minority, a sexual minority. People who feel as though they're somehow excluded from the greater population as a whole talk about these feelings of stress, really. It never goes away. We've had two panelists just before this, and both of them talked about this, where it's overwhelming, that it's just there, that it becomes something that isn't avoidable. And particularly with chronic stress, that's an important facet of it, that you are both overwhelmed and you feel as though there's nothing you can do. And that's the scariest part of it, that there's nothing I can do. Looking at this from more of a medical standpoint, there's literature out there talking about the HPA axis. That's pretty much how your brain talks to the rest of your body and kind of processes stress and controls your cortisol levels and different chemicals within your system to kind of take care of you when you're at these times of stress, to get you worked up when you need to be worked up, to calm you down when you need to calm down. But what happens here is that because you're constantly stressed, your body is constantly in a state of hyperarousal. Your cortisol levels are a little higher than they should be, and they never quite come down to where they're supposed to be at baseline. And that has significant maladaptive effects. It has significant physical, medical kind of effects. And we can talk about psychological disturbance, but in addition to that, there's also cardiovascular disease, metabolic dysregulation. Big picture, your body doesn't function right. When you're constantly stressed out, when you're never going back to the baseline, that's not how your body's supposed to be functioning. That's not how your body's at its best. And this has been looked at in multiple different communities. So we've talked about in the literature, looking at the African American community a lot. We also look at the Latino American communities. We also look at Native Hawaiian communities. Actually, have a lot of research done in this field. But you begin to see a multitude of different risk factors developing. And instead of going through each one of these, I want to give us a big picture on it, because there are a lot of different bodily effects that you kind of experience when you're going through this. Your risk for these different diseases in these different states is heightened. Particularly cardiovascular disease is a big issue. Looking at just diabetes, for example, as well, you see those numbers spiking upwards when people are experiencing more distress. You also see this with an unrelated population. If you're in a workplace and you feel as though you're discriminated against in a workplace for whatever reason, you see similar effects. Chronic stress, for whatever reason, has a bad effect on your overall well-being. An interesting population to talk about is also the LGBT community, particularly because this is one where often lines aren't drawn by race or identity. There's not a lingual kind of gap. It's different from me. I'm born as an African American, and this is my kind of identity. You can see people from the LGBT community are quite diverse. And because of that, it's important to recognize as Muslims that we also come from a very diverse background. Regardless of where we're coming from, our experiences as a perceived social outcast, or perceived as though we're excluded from the normal kind of society as a whole, has these parallels within a multitude of different communities. For example, CARE did a report here in California where they were looking at what's happening in our schools. Yes, we're seeing bullying. Yes, we're seeing a lot of these different chronic stresses from a young age. But what's important to recognize is that in communities where we don't have resources in place, and we were just talking about this in our last talk, when there's not these safe spaces to go through, where there's not resources being developed, where these skills are not being taught, we deal with it with maladaptive behaviors. You see in the literature that people start turning towards things like tobacco, like alcohol, like even violence, to deal with these issues and this chronic stress that's been pent up inside. And we have these long-term effects that both are physical in their nature, as well as now these social issues that begin to develop and have their own effects in the long run. So again, giving us a big picture of what chronic stress can do to you, in every direction that we look at it, whether you're looking at GI function and acid reflux and diarrhea, we can turn to even acne and hives, and we're going into more chronic conditions like hypertension, diabetes, eating disorders, psychological issues in terms of sleep deprivation, neuro issues in terms of migraines, chronic fatigue. The list goes on and on. There's just an incredible amount of research being done, and this list seems to grow with time. So really what it comes down to here is a couple of conclusions. Yes, there's a lot going on in our community. Yes, we've got this whole new facet of chronic stress that didn't exist maybe 15 years ago, or at least not at the level that it is today, and unfortunately seems to be growing in a lot of ways. Yes, the American Muslim community is struggling with this. We have our own internal issues in terms of stigmatization, isolation, rejection of just developing some of these basic programs that we need to be able to cope with a lot of the issues that we face. And finally, that because of this new modality of chronic stress that's developing, we really need to do a better job at studying this. I was recently in Detroit for the Muslim Mental Health Conference, and there we were actually talking a lot about these issues. We were talking about chronic stress and how it affects us and how we deal with it. But what was striking was that every time we talked about a model being used, we talked about models being taken from other communities, from our studies. It's because we haven't developed our own yet. It's because the literature just isn't there where it needs to be yet. There's so much work to be done, and it's incredible that we're seeing people come together, but it's important that we walk away building on this and continuing to work at our respective fields on these issues, because there's just an incredible amount of work to be done. And again, just in closing, this quote from Ibn Sina, who's been called the father of modern medicine: the knowledge of anything, since all things have causes, is not acquired or complete until it is known by the causes. Therefore, in medicine, we ought to know the causes of sickness and of health. And I think he relates to us the responsibility that we have to begin to talk about this, to begin to really discuss this, and to take action. And most importantly, inshallah, and I say that knowing that student from Berkeley probably went to somewhere close to here that got picked up the flight a few days ago, inshallah, we're able to take the first step towards addressing this. Thank you.
Hammad, they are doing something quite right at UC Davis. I think that you could come back to Cal and teach Public Health 101. What do you think? Thank you so much. We have heard from our panelists, and in a moment we're going to open it up to the audience for any questions or reflections you have to share. I'm going to pose the first question though. I was struck that all three of you touched on the issue of our children. Recently, CARE did a study in California that showed 50% of Muslim kids K through 12 experience bullying in school. What was even more striking was that the source of the bullying for 20% to 25% of those children were their teacher. I want that to kind of settle on us and the power of adults in this issue of Islamophobia as it affects our children. And thinking about the anxiety for our children that Khadija brought up, and this issue as it relates to stress. I would love for each of you to share your reflections on the impact on our children and some ideas around what we can do to address the issue of protecting the mental health of our children.
I think, support groups are key, where our youth can talk about what's happening. And it has to be done, or it can lead to a lot of the issues you talked about. So support groups are key. Letting them know about services. I've recently seen in many doctors' offices that are Muslim, they'll actually have now a psychiatrist nearby or a social worker, so there's more of that. In Canada, there are more places where they actually are hiring people within their mosques to provide services. So I think that's one of the things that we can do.
So going off of what you said as well, here actually in the Bay Area, I'll speak to locally the efforts we've done here. There is a center that's now called the Khalil Center, which is a Muslim counseling center that's opened up in the South Bay, specifically because I feel that there's really a need to address mental health issues in the Muslim community, not just our youth, but really all people. But it's interesting that since we've opened, which has just been since October, so it's only been a few months old, although it is part of an umbrella organization that's part of a 6-year-long program that first started in Chicago. And it's really wonderful that it really brings in the mental health aspects for those who are professionally trained therapists and counselors and psychiatrists, but also brings in the faith aspects in counseling, which I think is a really important intersection to talk about. And really what we found is the community has been really receptive to this idea, and the youth in particular. We have so many young people who actually come and use these services, and we have set up support groups and grief groups. For example, right after the San Bernardino shooting, which really affected that particular community since that person was from that community, and a lot of the youth were really kind of reeling after that incident. I think, Allahu Alam, had that support network not been in place, I think the youth would have continued to be reeling. I think it was really important that they had a space to come that was safe, to be able to talk about their feelings and their grief, and really figure out next steps. We did the same kind of support work for parents who were really terrified about what this meant for their children, and so on and so forth. So these services are going to become only more important as we go forward.
I think those are extremely wonderful suggestions, particularly getting those safe spaces going and being able to talk about these issues and validating the issues that we face and this kind of the concerns that we have. I think particularly with students on college campuses after San Bernardino, after what happened in Chapel Hill, those vigils and things like that were done make a difference. I think it validates the concerns that we hold, it validates the feelings that we feel, and it really gives us an opportunity to express ourselves in places that are healthy to be talking about these issues. Additionally, I think it's important for us to talk about when we see these surveys come out, when this bullying is happening. Just because the number says something doesn't mean that somehow your kid is excluded from these numbers. Because your child doesn't tell you this is happening at his or her school doesn't mean it's not happening. And I think it's really important for us to recognize that these are kids coming from our families, from our households, from our group of friends and our social circles. And for us to talk about this at homes, in social settings, and at places that our kids can start talking about this, really addressing this, so we can take action when action needs to be taken as well.
Thank you.
I just want to add a little bit to that. One great service that we have now is spiritual care services in Islamic chaplaincy. A lot of our brothers and sisters at the colleges, hospitals, and also the prisons that they help and they give talks. They also give them advices, and we hopefully, inshallah, at the Center for Islamic Studies want to have an Islamic chaplaincy program that we can train students and community leaders that they can go out there and help all our Muslim brothers and sisters.
Wonderful.
Thank you.
Thank you. I'm going to defer to Hatem.
In thinking about the shift to public health, we're having also an intervention from government CBT programs that are attempting to look at the public health of the Muslims from a security or securitization of public health, which creates a crisis and a barrier for the community, because am I speaking to a public health provider, or am I speaking for 007 that is wearing a medical outfit? So how can we begin to navigate this construct of securitization of public health and looking at the Muslims again as they're receiving public health to address an issue, they're being securitized and not being seen actually as a victim of whatever is happening in Islamophobia and other stuff.
Okay. Actually, Dr. Hatem, interestingly enough, earlier this week on Wednesday, I was at the Capitol by invitation of President Obama, who sent a mandate to Secretary of Health Burwell asking for leaders of Muslim mental health to come to the Capitol and speak about issues facing, all the issues that we talked about here, discrimination and so on, that is really affecting the mental health of Muslims. Now, interestingly enough, this conversation was specifically, and the only reason I agreed to go, was specifically because it was not a counterterrorism discussion. It was specifically on mental health. And had it been, anything to do with CT, I would not have been there, to be honest. I'm not interested in that discussion. It's an important one, but it's not up my alley. My alley, as a person who is a psychiatrist and someone who's also classically trained in Islamic sciences and trying to bring the two fields together, is really to understand what parts of our faith can actually be useful and helpful in helping mental health, the concerns of youth and adults here in America. So the conversation was a good one that started. We had SAMHSA and the Department of Health Services and so on attending, about 13 representatives from various government agencies. It was a listening session, listening to us 10 leaders or so speak about the various concerns that we have in our communities, the kind of research that we've been doing, the kind of program that we've been doing, and where we need to go from here. Because honestly, we're very young institutionally, and our infrastructures are not yet quite robust in dealing with these mental health concerns that are only increasing. Right? So it was a good start, I think, and I hope it will continue.
Thank you. There's a question in the back. You. A microphone is coming.
Hello, Laurel Ben Hamida from Muslim American Society Social Services Foundation in Sacramento and Reducing Mental Health Disparities Coalition in California. But I'm speaking on my own. Okay. So just a couple of things, but I'll be very quick. I think with the public health model, I've been worried ever since I went to a public health conference where I kept hearing the word surveillance and I began to feel creepy. And worried because other terms that are being used are immunization, contagion, and actually when the sister from India who spoke yesterday, one of the things I noticed, I happened to have my first visit to India recently, that when the Supreme Court in Delhi, yes, made the bail release for a student activist in India who'd been arrested for sedition and old British law for saying the word freedom and things like that. The bail was granted with the language of we're trying to immunize him, it's a disease, we don't want, it's sort of like we don't want to make him a martyr, so we'll let him out. So I'm concerned about that very much, and I think we all should be. Because after all, a lot of public health problems are caused by the social injustice in the environment, whether it's political, social, okay? And that's worldwide. The second would be, we have out of Sacramento from Muslim American Society Social Services Foundation starting a year ago, take this number down or this name, Amala Hope Youth Hope Line, started by youth who came to us because of a string of suicides in Central California. 855, that's toll-free US, 95-AMALA, and you can go to their website. They made a wonderful video, and they're there 5 nights a week, and that is from the community, okay? It is not funded except by the community. So, number 3, and this is very difficult. We're having a very difficult time getting brothers to step forward to be brothers, counselors, peer counselors. They don't have to be professionals. For, especially in our community where Awaad is traditional, who is going to counsel the brothers of all ages, young, middle-aged, old, who are suffering from all this trauma and stress? Are the brothers going to leave this to sisters to do? It's very concerning when you're on the ground and you're trying to recruit and every brother is too busy or no brother applies. And this is, especially this week, I've been trying to do that for a peer counseling training we're having, an 80-hour. That's a big training, but you need skills, okay, to do this work with people, to prevent the trauma from becoming PTSD, depression, and suicide. Okay? And then the brothers just aren't, they're not there. I don't think it's understood how many people of the brothers are how vulnerable they are because they're not supposed to show the vulnerabilities.
Thank you. Let's see if any of our panelists want to react to that. The issue of men stepping up or leading it as women's work with, which by the way isn't unique to the Muslim community.
Well, I guess it depends where. I don't want to generalize. I think it's a great call for the organization here for people to volunteer. I've certainly seen a lot of men step up. I was doing a study in Canada, and these guys literally, they looked at me and they said, "She seems okay." And I was like, "What's that about?" Okay, so then they go, "We're going to tell you where it's real at. These were the brothers." And so they put me in a car, and I was like, "Where am I going?" But I had a good feeling. So I went in the car, and they took me to a place where they deal with addiction with the Muslim brothers, crack cocaine. And it was in the back of a mosque in Ottawa. And so they did so privately. And I think we certainly have a lot of brothers that do a lot of things. I think maybe a call in your case here for people just saying that your organization might help. There's so many amazing contacts here. My own experience has been very positive. So.
I can't say enough good things about what they're doing at Amala as well. Being from Sacramento, I know Kareem and Ariba and a lot of these people that are involved in this. And this is a youth-driven project, really. A lot of college students, a lot of now graduate students are working on this. And it's something that was where a need was identified in the community. And people realized that if there's no one else stepping up, I need to do this. And I think that kind of ties back to what you're talking about as well with the males in this field and helping and being part of the solution as opposed to strictly sitting on the sidelines. I think as we develop these conversations, we'll begin to have more people joining the conversations as well as taking initiative and becoming part of the solution. And inshallah, that's where we're heading towards.
Thank you. Oh, we have quite a few hands. About here in the middle, can you go to the gentleman?
Assalamu alaikum, everyone. First of all, thank you, Dr. Hammad, for organizing this Islamophobia conference, and thank you to the panelists for your amazing talks. We're talking about public health, and my name is Syed. I'm a medical student in New York, interested in public policy, and I'm curious to know, the findings that you have, each area. How has it translated to the policy work? Or what are some of the vision, or where do you see policy coming in to enact some of these changes that you're highlighting?
So I can speak at kind of a micro level, being that I'm a medical student as well. One of the things at the UC Davis School of Medicine that we've actually talked about is how do we address this as students? As part of medical school training, you're talked to a lot about cultural competency, diversity training, things like that, because our populations that we work with will often be coming from very different backgrounds than ourselves. And one of the topics that we brought up as a Muslim community at the campus was how do we talk about Islamophobia? And what's difficult when it comes to these conversations is that there's not as much research when it comes to patient care and things like that, or even workforce discrimination that we can back up our claims away. More recently, there was a really groundbreaking study coming out of the University of Chicago by Dr. Khadija looking at workforce discrimination amongst Muslim physicians and talking about perceived discrimination in that setting. So I think that alone, one major study like that, opens a lot of doors and allows us to have a lot of important conversations when it comes to being advocates. So I think that's a big part of it, getting the literature developed to the point where we can ask for things to be put into curriculums and starting to take somewhat of a small-scale policy change approach like that.
I'm just going to piggyback on that and say I absolutely agree. it's interesting. I'll speak from the point where I think it's really important that we have research, actually grounded research that actually speaks to the problem. You know, one of the things I felt when I was there on Wednesday, for example, presenting to high level, and this year I'm talking more bird's eye view on the federal level, you know, there's, you could tell narratives, and narratives are important and powerful. And much of what we actually presented today were narratives. But when you have hard evidence, right, and then you have programming that's evidence-based, as we like to say in medicine, right? And you're able to actually prove pre and post that this has been effective, then you can take it to the policy level and make sure that it actually, or hope that it actually does affect policy. But until you have that important step, narratives aren't going to quite cut it. And so I say that, after I finished my training at Stanford and was hired onto the faculty, the very first thing I asked for was to have the ability to have a research lab. And so we have what we now have called the Stanford Muslim and Mental Health Lab, in which there's a dozen researchers doing about 8 different lines of research. And my whole point and hope in that is that you have actual solid evidence-based research coming out of it to be able to then take it to the next level and say, here is what's going on. Here's the pre, here's the post, here's our programming, and this is where the policy needs to change. And I really feel until that happens, we're not going to quite cut it. So hopefully we'll have more people join the bandwagon.
Thank you.
Assalamu alaikum, my name is Khaja. I live in Sacramento. I have more of a suggestion than a question, and I'd be curious to hear your feedback. And in my opinion, the Muslim community's approach since 9/11 has understandably been one of, we're human like you, and we need you to accept us as your equals. In my opinion, that's disempowering and self-defeating. I'd like to quote Jada Pinkett Smith, who said in objection to the racism at the Oscars recently, begging for acknowledgement or even asking diminishes dignity and diminishes power. My family's from Baghdad. I counted about 60 relatives of mine the night of the war in March 2003. And despite the fear, despite the worry, not just for backlash against me as an Iraqi living in the US, but for my entire family and my civilization in Iraq, I was compelled to organize against it. I went to the streets and I protested as loud as I could to call out the criminals who were destroying my people and my civilization. Had I stayed at home and watched TV and cried about it, or begged for legitimacy from my Christian and Jewish neighbors, who, by the way, joined me in protest, that would have been much worse on my well-being. So I humbly propose that it's a mistake for us to separate our plight from the plight of people in Palestine and in Iraq and Afghanistan on the growing list of majority Muslim countries that are being targeted by the wars. So clearly our We're Humans Too approach has not helped on that front. I think that we need to just from practical, not even from a moral perspective, just from a practical perspective, I am not more valuable than the Iraqi who had it worse in Awaad. That's just a reality, and we need to speak up against that as an extension of their humanity, of the humanity that we have in common, if not as an ummah. So I'll just end with a quote from Malcolm X, which I think is very helpful in order to guide our thinking. He talked about the war on Congo, and he said, quote, "They're able to take these hired killers, put them in American planes with American bombs, and drop them on African villages, blowing to bits black men, black women, black children, black babies, and you black people sitting over here, cool like it doesn't even involve you. You're a fool. They'll do it to them today, and they'll do it to you tomorrow, because you and I and they are all the same," unquote.
I think a conference that gets a quote from Malcolm X is always a success, so thank you. Any reactions or reflections?
You have no argument here.
We're saying go ahead, sister.
We're the same family.
Preaching to the choir. Thank you. Other, yes.
Hello everyone, my name is Rania. My question is directed at all of the panelists. Today we talked a lot about collective problems and the difficulty of addressing them, especially when they're not covered or they're not, they're not kind of acknowledged in society. And I guess my question is, what, on an individual level, can we do to reduce chronic stress, both for our own kind of mind, body, spirit, physically, and also in order to kind of spread that, because it's very difficult to address such a collective problem in society when it's just you, or maybe you and one other person or two other people. So yeah, that's my question. Like, what steps can we take as individuals to take care of ourselves and our communities?
There's been a lot of evidence-based research on this, and there's so many things we can do. Individually, yoga, there's actually been research in doing, using yoga also as intervention techniques with addiction and different kinds of stress. And certainly exercise. I will say, not being afraid if you need to get on medication, and not being afraid to go to somebody who can prescribe that. I'd also probably suggest counseling. I think we're getting better at reaching those services, much better, and so that's certainly helpful. And support groups, and there's much more evidence-based research on I think one of you talked about it, or both of you, healthy lifestyles, and really taking care of ourselves. I mean, yesterday I was talking to a couple of women on this conference, and the topic and how exhausted we were at the end of the conferences, and we go to conferences all the time. It was just like, whoa, because it's us, it's our lives, right? And so there was a student I talked to, and she said, I literally had to separate and just detach, and going into that silence. I think each one of us knows what works, what doesn't, but those are some of the things I have found helpful, but I'm curious to hear what people think.
I'm just going to add, I think that's wonderful advice. And I just wanted to add maybe just one more piece to this. You started giving with sit-down, so I imagine that you're coming from the Muslim faith tradition. And I just wanted to add that a lot of people have found their own faith tradition to be very useful and helpful in actually helping with these feelings of trauma. Often we don't know exactly how to access that. Interestingly, this Khadija Center that I was referring to, that's kind of bringing Muslim well-being and counseling, or Muslim spirituality into counseling, I think has been very useful. And I'll just give you a very small snippet of how I came to really realize that this was the case as well. Some of the research I have been doing, one of the lines of research we do is actually historical. And it's taken from really the manuscripts of the golden era of Islam. And this is, as Muslims who are familiar with this golden era, are always very proud of our golden era and very proud of the advances of science and medicine and so on at this time. So I thought to myself, it really can't be the case that you have so many advances in every realm of medicine and the humanities and sciences, and mental health was completely ignored. So what I came to find through this research, and I'll just quote one scholar, Imam Berkeley, who I've published on, who's really done a phenomenal, and his book actually is called Sustenance of the Body and Soul. So you've mentioned mind, body, medicine. This is 9th century. And in his discussion, he talks about he has different chapters of different illnesses, and he talks about what's most striking to me, especially as someone trained in modern psychiatry, is the fact that he talks about it's a three-pronged approach. So there is what he termed then herbal, which today we would call medication. He also talked about talk therapy, which was so novel, and he might actually be the very first person in history, and we may credit CBT or cognitive-based therapy, talk therapy, to him until otherwise proven. And third, he talked about spirituality. That even though we come from faith traditions and people tend to say, well, if you're just stronger in your faith, you'll get over this. In reality, he's saying, even if you have a faith tradition you can rely on, there's also these other two prongs that you must adhere to as well. And so this is 9th century. right? That's a very long time ago. But that holds absolutely the case, and it's exactly what modern medicine and the modern fields of psychiatry and psychology would say. So I just want to bring that in and also remind us that often we have, if we come from a faith tradition, often there's a lot of help in that tradition as well. So I encourage you to pursue that as well.
That's wonderful. Hammad, do you want to add anything?
I think it's difficult to add anything to that. I think that's just so complete. I think the only thing I would add, we mentioned a little earlier, when events happen, when San Bernardino happens, when Chapel Hill happens, a lot of people from my generation, kind of being the social media addicts that we are, we turn to Facebook, we turn to Twitter, we let ourselves express ourselves through that way. And I think at a certain level that's also healthy because it allows us to have some of these conversations. So I think for each of us, we have our own way of dealing with things, but it's important that we do have a way of dealing with things. That we're able to follow down one of these roads that have been mentioned just now, or that we found our own ways to kind of approach this and make sure that we're processing these emotions and not just letting them kind of settle in and dealing with them as an individual alone.
Thank you.
Just three other things for your toolkit. Humor, they say satire will not defeat people who oppress you, but it will help you to laugh. So political satire can be helpful, and we get that from social media, but nowhere else. The second, and this is I think traditional for us, is perfumes, scent, aromatherapy. I'm carrying it in my purse all the time now. And I'm just like my mother-in-law did in Algeria, I'm offering it to sisters. And I know the brothers like it too, so I leave you that here. I actually bought some of it outside the seminary in Lucknow. I'm wondering. And the third is massage and touch.
Yes.
When I go places, I see a sister who's been working really hard cooking for an event. I give her a neck rub. You can do that in your family. It's really great. And we know the hammam has sustained men and women in the places from Turkey to India to Morocco. Every Friday going to the hammam. That's very traditional.
Thank you. Those are excellent suggestions.
On the humor, that's why when we go through the airport, the TSA always gives us a massage.
When I'm bumped.
So, and touch.
If we're lucky, Hammad will come up for some stand-up later.
And I always ask them to thank me because without Muslims they would not have a job. So being a Muslim is a stimulus to the economy. So we managed to learn. But I think we've been having some discussion with San Francisco General Hospital on dealing with mental health, with health issues relative to Muslims. And maybe if I could propose for us to put together a consortium, because we have Stanford, Berkeley, San Francisco General Hospital, Zaytuna, GTU, San Francisco State, and put a consortium with the idea of research that is looking toward applied research to drive policy. Because without policy change that can end in making an impact, we still would be running around on the same circle. So maybe we could put that consortium and begin to drive on a national level that aspect in terms of Islamophobia and public health in general.
And includes social workers.
Social work and Indiana University too.
And we might get Hammad to come do his residency at UCSF, which a large part of that is done at San Francisco General.
Unless we take him to Stanford first.
we can arm wrestle. Thank you. We've had some great conversations around that, and I do think that some applied research, translational research into best practices to support health outcomes for Muslims, not only our patients but for our staff, is what's already been mentioned. We are so lucky to be in the Bay Area, the greater Bay Area. There's not a shortage of opportunities and resources. I think it's just really incumbent upon us to take action. Yes?
Hi. First of all, apologies, I came a little bit late, so maybe you have had this discussion of this, but I want to follow up on what Dr. Bazian has spoken in terms of the the fact that we are at academic institutions, we're producing knowledge and including people who are social workers, who are in the field, it's also producing knowledge as we go along. And I want to kind of like, I don't want us to end without thinking about the collective responsibility. And some people have spoken about it in the panel, and the collective aspect of the collective mental health of the community. In terms of separating between what is it exactly about being Muslims today in this particular day and age, and what is it about being part of marginalized communities that are targeted by racism and all sorts of other ways of discrimination. Two is the question of the responsibility of people who produce knowledge. The American Psychological Association already has a huge scandal, and I don't know if people talked about it, in terms of actually signing on the torture techniques. I mean, there were people, leadership in the American Psychological Association, and they basically got away with a slap on the wrist participating in that. So I find it really hard for us to kind of say that we are only going to be dealing with counseling our clients, and we're only going to be providing one-on-one mental health and so on, and we're not going to be dealing with the question of what the US government is doing and so on. I don't think we can get, I mean, even if we want to, even if we would like to do that, it is impossible for us to live in a cocoon. Even in ivory towers, we are unable to do so, because we are producing things that affect the community, and we are influenced by the community. So even if we say we don't want to, being neutral in these issues, we're actually complicit in perpetuating the wrong. So I think I would like us to kind of be more proactive, to hold ourselves accountable, because we are the ones who are holding responsibility for the mental health of our community, for the health of our community. So we really need to also check each other, and we need to be responsible in these issues. Thanks.
Thank you. I'm going to check for any reaction here.
You're on your team.
Yeah. I think we have time for one more question. Yes.
Hi. So I'm just curious to know about the perspective or the current established funding apparatus for the various research that's being carried out, and if there's thoughts on how to potentially expand that for interested individuals that may be sort of aspiring to lead, if not to take on the roles that those of you who have. Because I'm aware that research at academic institutions is very limited and very contingent upon funding from state, national levels, and in places where the research might need to be carried out, it may not be politically viable, and unfortunately will sort of hold back necessary findings that could carry this to a more established location where we can impact policy, as Dr. Awaad had alluded to. So I'm just wondering about the funding apparatus, if you can speak to that, please. Thank you.
There's quite a bit. I mean, the key thing, whether it be SAMHSA, NIDA, NIH, or I mean, the project we're running right now with University of Missouri. It's their design. It's a long title. Myself and a team are working with the center, and that's a SAMHSA grant that's actually going to be looking at sort of Black Lives Matter, the impact, the media role on sort of young adults, and then whatever the media role on young adult Muslims. The key thing is what we have learned, and I work with some people that I call the banks. They're just, they just have a knack of getting money in this competitive climate, is just the interdisciplinary and cross collaborations between universities, interdisciplinary. It's so key, you know, right here, and that's probably one of the secrets. There are many avenues. I mean, within universities, as you know, we have databases. We sit down, we meet with them, we put in keywords, and then we'll just get tons of grant possibilities. The key thing I've learned is you have to have a balance in your personal life. Grant writing is tough, and you want to see your spouse, your partner, your cat, in my case, and having really great research assistants. So those are some. I mean, there's so many. Do you want to add to some of the grants?
there's, to answer your question, there's good news and bad news. And I'll start with the bad news first, and then end with the good news. It's incredibly difficult, as you alluded to, and it's very limited. In fact, one of the very things we were presenting this past Wednesday was the fact that it's quite limited for Muslims for people who want to study Muslims. It's incredibly limited. Not just Muslims, but really any faith groups, because they don't really make any of the cuts for Samhsa grants or government-based grants, NIH grants, etc. So for me, just to share kind of on a personal track of what exactly happened, and I would say if you're in a training program, use as much time as you can and devote yourself to the research at that time, because the grants that are there that are available during training is incredibly useful and helpful. So for example, I had a Samhsa grant and several NIH grants during my training. Because they were trainee grants, they were even at a lot of flexibility. So hence all of this work on Muslim mental health started then. Once I graduated and once I was done, it was incredibly difficult to find the same grants. So here's where I'll share the good news. I had a mentor who was over at Duke University, studying mental health and Christian faith, so similar, but kind of an interesting intersection as well, and said, look, is this research important to you? I said, absolutely, this is exactly what I want to do. Do you feel that you're going to be able to sustain this and have the laser sharp focus to really be able to continue doing this? I said, absolutely. He said, then do you really need the funding? And so it's one of those questions that really trip you up, and then you have to really think about it. It's a little bit existential, if you will, to think about what that means. And the reality is in our lab, so much of the research we do that's really, I would say, groundbreaking, so much of it is unfunded at this time. Now, I hope that's not always going to be the case. I realize some of this is very pioneering, and it's going to take that kind of research then to have people convinced that this needs to be funded, whether private or through other agencies to fund it. But really, sometimes we just need to get out there and start going at it, right, and doing the actual studies, and then actually hope that that puts funding in place. That's kind of the reality of where things are right now.
Can I just add something? The Pentagon, now this is where it gets a little quirky. So the Pentagon has an extensive amount of funding on different projects. And you'll have a lot of people doing research on Muslims that aren't Muslim, but they're getting grants, writing about us, getting these centers, whatever. And so if you're comfortable, applying and your question about our thought about surveillance and the Pentagon, but my own personal belief that if there are going to be a lot of people writing about our communities who hardly interacted, they're getting grants, well, I'm going to be in there. So I did one. I'm waiting for the team for it was small, 1.5 million. I was a little nervous because of the issue you raised, but I'm okay with it now. I'm getting more comfortable because I think we need to own that. That's a mechanism. It's a powerful mechanism. Some people may not be comfortable with that, and that's okay. So it depends on your own level as well of assumptions and who you're comfortable requesting money from.
Just to follow up that, do you think our community has the financial resources and where it stands today to support research on a private level, like you mentioned, foundations or non-governmental sources?
Some communities do. The Aga Khan Foundation, I'm very familiar with that. Some do. I'm not an expert on that question, so I don't know.
I'll just add in, some communities do, and I think we need to convince them that this is actually the right place to put those funds.
Yeah.
Hammad?
I was just going to circle back to the first question. Just as a student, I know a lot of people in the room are faculty as well. Open your doors to the students. We have MSAs on campuses across this country filled with people that are interested in research, people that want to tackle these issues, people that want to take some action and not just be talking about this. Give them an opportunity to work in your labs, to co-author with you on something, to just learn about the grant process, learn about the research process, think about a career in academics, because I think there's all these opportunities that you may know as a faculty member or someone who's a little bit further down the road, but there's people that are still working on figuring out what they want to do with their lives that would really benefit from learning from you about that.
Just in terms of the funding, while we might have individuals that are affluent that could donate, we still don't have the institutions institutional, foundational structure for Muslim-driven research that is owned by the community. And that will take qualitative and quantitative change to occur. So we're still dependent on external sources of funding for a lot of the work.
Thank you. I'm going to let Dr. Bazian have that final remark. We've come to the end of our time together, but I want to thank our panelists so much for sharing your wisdom with us, and we do have our marching orders. Yeah, we have a lot to do. I believe we have a break now. Okay, and we're going to reconvene at 11:30.